Welcome to the AFib Virtual Education Summit, sponsored by Johns Hopkins University School of Medicine on CardioCare Live. My name is Dr. Joseph Marine, and you are tuned in to a live session called Atrial Fibrillation, from Pharmacotherapies to Interventional Approaches with Dr. Hugh Calkins. Before we get started, I would like to remind our audience that we will be taking questions throughout the presentation. You can send us your questions through the box in the lower left-hand side of your screen. Dr. Calkins is the Nicholas J. Fortuyn Professor of Cardiology and Professor of Medicine at the Johns Hopkins University School of Medicine and Director of the Arrhythmia Service and the Electrophysiology Laboratory at the Johns Hopkins Hospital. His research is focused on the areas of atrial fibrillation, catheter ablation, syncope, arrhythmogenic right ventricular dysplasia, as well as other heart rhythm conditions. Dr. Calkins, it's great to have you with us.
Well, it's great to be here, Joe. So today I'm going to talk to you about atrial fibrillation, and we'll talk about drug therapy and interventional approaches. Here's my conflicts of interest. In terms of the outline for this talk, I'll first provide an overview of atrial fibrillation. We'll then talk briefly on stroke risk and anticoagulation. I know that's been covered in some of the other sessions today, but we'll touch on it briefly. We'll then move on to the whole area of rate control, antiarrhythmic drug therapy, catheter ablation, and then we'll wrap things up, and hopefully in about 30 minutes or so before we have time for questions and a further discussion. Now, atrial fibrillation is an important arrhythmia for many reasons, but the first reason is that it's remarkably common. If you look at the numbers, it's striking. It currently affects 5.1 million Americans, and it's estimated that by 2050 the number will increase to 12.1 million Americans. And this is obviously the tsunami of the baby boomers, becoming in their 50s, 60s, and 70s. Now, AFib is more common in men than women. It's more common in whites than blacks. And if you think of anyone who's the age of 40, there's about a 1 in 4 chance during the rest of their life they may develop atrial fibrillation. So this is a common problem. Your friends have it, your parents may have it, you may get it. And certainly lots of our patients have this condition. Now, atrial fibrillation is also important because it increases stroke risk. And if you sort of think in broad numbers, you would say, well, a patient with AFib has about a 5-fold increased risk of stroke. But that risk depends on other risk factors. There's low-risk patients with AFib, and there are high-risk patients with atrial fibrillation. And we'll discuss ways to risk stratify them in terms of their risk profile, which obviously impacts their treatment strategies. Now, atrial fibrillation is important from a sort of an overall healthcare costs or a hospital administrator standpoint because it's a very common cause for hospitalizations. It's the most common cause why patients with arrhythmias are hospitalized. And certainly if we think about our hospitals, they're filled with plenty of patients with atrial fibrillation. Now, atrial fibrillation is also important because it increases mortality, and there's been multiple studies that have shown this. And after doing all your multivariate analysis and trying to correct for every other variable, at the end of the day, patients with atrial fibrillation don't live quite as long as those without atrial fibrillation. Now, this discussion I don't find terribly helpful because there's no treatment for AFib that's been shown to increase mortality with the exception of anticoagulation, but clearly this is a serious arrhythmia. And then atrial fibrillation is important because it impacts quality of life. And this slide from one study compares the general population, which is shown in the green bars, with patients with a recent MI, those with atrial fibrillation shown in the aqua-colored bars, and those with heart failure. And if you look at the various metrics of quality of life, whether it's physical functioning, vitality, general health, mental health, emotional health, social functioning, in all of them you can appreciate that those with AFib shown in that light blue line are clearly markedly reduced. And ultimately, the main reason we treat patients with AFib is to make them feel better in addition to the stroke issue. Now, there's some new data reminding all of us that AFib is linked with dementia. So this is a study that the group in Utah did where they looked at a large sort of healthcare database and they found that patients with atrial fibrillation had a much higher risk of all types of dementia. And the AFib patients are shown in the clear bars, the non-AFib in the dark bars, and this obviously is concerning to anyone. Now, this is not a definitive study, but there's 2 or 3 studies sending us the same message, that there's also a link between AFib and stroke risk, but AFib and dementia. Now, we've learned a lot about AFib in the last 20, 30 years. 30 years ago, when some of us were in medical school, we were taught that atrial fibrillation was due to multiple reentrant circuits swirling around the atrium, that you needed 3.1 of these circuits simultaneously swirling for AFib to continue. And that was partially correct. More recently, in 1998, the group from Bordeaux, France, discovered that AFib is triggered from the pulmonary veins, and also involved in the triggering of AFib or autonomic ganglia. Now, if you look at these, these figures which are shown here, you can see this is looking at the posterior wall of the left atrium. You can see the 4 pulmonary veins, and there's muscle fibers in these veins, which is where AFib arises from or is triggered from. And then you have these pink autonomic ganglia, that the firing of these ganglia seem to light up the pulmonary veins and light up these bursts of atrial tachycardia that trigger AFib. So it's a much more complex arrhythmia than we imagined before, and now the pulmonary veins we now realize are important aspects of AFib and its treatment. We've also learned that AFib causes remodeling of the atrium. So the longer you're in AFib, the atrium will stretch and dilate and scar, the electrical properties will change, and this begins very frequently with the onset of AFib and continues. And I think any experienced clinician recognizes is if they see a patient who's been in AFib for a year, 2, 3 years continuously, not surprisingly, the atrium will be dilated on an echocardiogram, maybe 5, 6 centimeters instead of the usual size of less than 4. And it's going to be a much taller challenge to get that patient back to sinus rhythm and keep them there than the patient with new onset AFib that may have gone on for an hour or 2. I think most of us know that AFib usually starts and it's self-terminating. Whether you give them, saline or just wait a little bit, most AFib, when it begins early on, will self-terminate. But obviously, if you've been in it for a long time, it's very unlikely to correct itself. Now, if you think about the conditions associated with AFib, there's a long list of them. And I think we appreciate probably the most important is age. Again, rare before 50, you hit 50, the incidence of AFib, prevalence of AFib starts to increase. By the time you're 80, 1 in 10 people have AFib. But AFib is also more common the more other comorbidities you have. So more common with hypertension, more common with obesity, and we've heard a lot about sleep apnea. More common if you have thyroid disease or if you have other diabetes and so forth. Now, AFib's also again been shown to be more common in men than women. It actually has an increased prevalence in high-level athletes, and it's more common in tall rather than short people for whatever reason. So there's a lot of studies that give us a sense of the likelihood you'll get AFib. Now, AFib also runs in families. So if you have a family member who got AFib, particularly at a young age, that significantly and fairly dramatically increases your risk of AFib. So if you have 1 or 2 siblings with AFib, you better watch out because you likely may be next. Now, this is some data showing the relationship between AFib and heart failure. And on the horizontal axis is a whole bunch of heart failure studies. I think most of you will recognize some of these names. And they're organized by those studies that enrolled class 1 heart failure patients on the left, with those that enrolled class 3 and 4 heart failure patients on the right. And then the prevalence of AFib in that subset of patients is shown on the vertical axis. And you can appreciate as heart failure gets worse, AFib becomes more common. And I guess that's not terribly surprising. Now, the other thing I want to highlight before we get into treatment is the important issue of how to classify AFib, or what the language is we should use when we talk about patients. So there's really 3 types of atrial fibrillation. There's paroxysmal AFib. This is AFib that starts and terminates spontaneously within 7 days. Or if you rush in and cardiovert a patient, if you cardiovert them within 48 hours, you would still probably call it a paroxysmal patient because the AFib likely would have stopped on its own. Now, persistent AFib is AFib that's lasted more than 7 days, or you need a cardioversion to terminate it, after 48 hours. And then there's a new term that many of you may not be that familiar with called long-standing persistent AFib. Long-standing persistent AFib describes patients who've been in continuous AFib for 12 months or longer. So this term highlights the issue of remodeling and how that impacts treatment strategies in response to treatment strategies, and it's been increasingly adopted all over the world as an important term. And then the final term we have is permanent AFib. Now, permanent AFib doesn't so much describe anything about the AFib, but it describes a therapeutic strategy where the patient and physician together have decided not to pursue a rhythm control strategy. So if you and a patient decide, look, they're asymptomatic, you're going to anticoagulate them, you're going to leave them in an AFib, you aren't going to cardiovert them or whatever, then you would say this patient with, we'll say, persistent or long-standing persistent AFib also has permanent AFib. But if some other doctor sees that patient and says, I want to cardiovert him, well, then you would take away the term permanent AFib and you would try to get him back to sinus rhythm. Now, a term you don't see here is chronic AFib. And chronic AFib we basically think is a fairly unuseful term, and we encourage clinicians and practitioners not to use that term because it really doesn't have a very good definition.
So Hugh, why don't we pause here and take some questions. Thank you everybody for sending your questions in. Please continue to send them as we go through the presentation. Here's one. Why do young athletes, particularly taller people, often develop AFib? Is there something that happens in utero or congenitally that predisposes them?
Well, I think the link with high-level athletes has to do with a couple things. One is they have high vagal tone, and we've talked about the fact that that the autonomic nervous system seems to play an important role in AFib. So that may be one factor. You would think, well, folks with high vagal tone, great athletes, high vagal tone, they should have less AFib. But we really find that a number of these people have actually more AFib than the folks that are sort of moderate athletes. The height thing is difficult to explain, although one way to think of it is, the heart sort of hangs in the chest. And if you're very tall, your heart may have sort of a longer shape and it's pulling on the pulmonary veins. That's how I like to think about it. I don't have that problem, but it's an interesting link, and it is borne out. Now, the other thing that sometimes you see in tall people, I used to think that sleep apnea is a condition you see in the obese, and that you could look at someone and if they're terribly overweight, you could basically predict they have sleep apnea. You ask their wife or husband if they snore. But I've also learned that those folks that are very, very tall with long, skinny necks can also have sleep apnea syndrome where they occlude their airway. So that may be the other factor that these really tall people, it's surprising to me, have more airway occlusion, more sleep apnea, and we all know that sleep apnea is an important trigger of AFib. So there's a number of different mechanisms, but those are the ones that I've thought about.
Here's another question on risk factors. Would you please explain the discrepancy between the fact that male sex is a risk factor for developing atrial fibrillation, but female gender is a higher risk factor for stroke in the CHADS VAS score? What about male sex predisposes to developing atrial fibrillation, or is that known?
As far as I know, that's just not known. What about testosterone? Triggers AFib. I think that's, I have seen no good studies on that. There's been studies with long QT syndrome and testosterone showing how that affects repolarization, but I'm unaware of any similar studies done in AFib patients. Now, the stroke risk issue, I think, is why women are more likely to have thrombotic events or strokes. Exactly what it is, lack of is it estrogen or I really can't give you a good answer to that. But I think it's well described, well understood. I think, as we'll get to later, if you're a woman and you have no other risk factors for stroke, you're less than 50 or 60 and don't have any other risk factors, female gender is not enough to push you over the line where you say you need to be systemically anticoagulated.
Mm-hmm. Now, height and gender are risk factors that are fixed. A lot of my patients want to know what can I do to reduce my risk of developing future episodes of atrial fibrillation. What do you tell your patients about food, habits, lifestyle, etc., who pose that question to you?
Well, I think the most important thing is the obesity issue. I think there's more and more data showing the link between obesity and AFib. There's been studies now done in Australia and New Zealand on fat sheep versus skinny sheep. And I think the science of that is very compelling, very strong. Similarly, hypertension. If you have hypertension, you want to be aggressive about treating it. Now, the other clear factor that can play a role is high levels of alcohol. I mean, the holiday heart syndrome, alcohol is a direct toxin to the heart. We all know on New Year's Day, lots of people have AFib. Now, I'm not big on telling patients with a little bit of AFib, they can't drink coffee and they can't eat chocolate and they can't have a glass of wine or a beer now and then. I think it's all about moderation. Rarely I've met a patient where they have one glass of wine, they go right into AFib. And for those patients, I say, well, you have to decide which you prefer. Do you like the wine, or do you like you're willing to get treated for AFib so you can have a glass of wine? But that's the exceptional patient. Most patients, they can have a cup of coffee, glass of wine, a chocolate bar, or whatever, and that doesn't trigger AFib. But I think every patient can do their own little experiment, sort of challenge test on themselves.
Here's another question for the audience, from the audience about sleep apnea. Do interventions for sleep apnea reduce the risk for development of atrial fibrillation?
My understanding of that is there's more and more data now showing that in fact is the case. And I know there's data on weight reduction and lower risk of AFib, and similarly there's some new emerging data with the sleep apnea. So I think treatment of it with CPAP does make a difference, and certainly I'm very aggressive about treating my patients.
And you talked about the interaction between atrial fibrillation and congestive heart failure and how the two are associated with one another. Do you approach that differently, atrial fibrillation differently in the heart failure patient in terms of being more aggressive about maintaining sinus rhythm or treating their heart failure to reduce the risk of developing AFib?
Well, I think that's a very important point. Is you see a patient with heart failure in AFib, and the question obviously is which came first. And we all know that AFib can result in a rate-related cardiomyopathy that can result in heart failure. And when you meet that patient, you have no idea which came first. Is this a patient with a lousy F from a dilated cardiomyopathy who then developed AFib? Or is this someone who developed AFib and the AFib caused the cardiomyopathy? In my practice, until proved otherwise, it behooves me, I feel compelled, to do everything I can do to not only rate control that patient, but get the patient back to sinus rhythm, then see what the heart function will do. And in the vast majority of the patients that I've dealt with, that I've met, the ejection fractions normalizes, the heart failure goes away. Typically what I'll do with those patients is I'll put them on amiodarone, get them anticoagulated, cardiovert them, get them back to sinus rhythm. If they don't want to be on amiodarone long term, I'll offer catheter ablation and then get them off all the drugs, and they end up, most of them, back with normal cardiac function, in sinus rhythm, off drugs. And so I think that's a very important point that you brought up, Joe.
Are there drugs that increase the risk of developing atrial fibrillation?
I think I think stimulants, alcohol, but that's inotropic agents, but not really many.
We have a number of questions about anticoagulation, which I think you're going to touch on now, and so I'll just pose one to you to kind of set that up. Should a 50-year-old patient be anticoagulated if he has paroxysmal atrial fibrillation, or until he is cardioverted, and for how long?
Well, I mean, that would come down to what his CHA2DS2-VAS risk score is. So if it's a totally healthy patient with paroxysmal AFib and no hypertension, no other risk factors for stroke, that patient is a sufficiently low risk that systemic anticoagulation is not indicated, it's not needed, with the exception, if the patient has persistent AFib and you're going to cardiovert him, then you have to anticoagulate him for 3 weeks before and after the cardioversion.
Great.
Okay. So let me go ahead and talk to you about treatment of AFib. And I think it's important, actually before I go into treatment, I just want to highlight that when you think about treating AFib, there's all sorts of guidelines you can read, and many of these are very well written, very good guidelines, but you should be aware of all the different guidelines and how fast they're changing. So, a guideline that for many years stood the test of time was the 2006 ACC-HA-ESC guideline on AFib management. Beautifully written, 100-page document, and this really was what we relied on for many years. Now, more recently, the European Society of Cardiology decided to put together their own guideline with John Cam. This was published in 2010. Again, a really beautiful document. My hat goes off to John and his team, but this was published in 2010. And then in 2011, the AHA and the American College of Cardiology and the Heart Rhythm Society said, well, we need to get an update of our 2006 guidelines because there's been some new anticoagulants and new antiarrhythmic drugs. They published this guideline. And then the Heart Rhythm Society put together a consensus document on AF ablation. This is an even longer document, 140 pages, but it's a very comprehensive document describing all aspects of AF ablation, from the science to the best practices and so forth. And then in 2012, the ESC came back with another focused update based on, really mandated because of some new antiarrhythmic drugs and some new results of antiarrhythmic drug trials. And then currently, the American College of Cardiology and the American Heart Association are doing a complete rewrite of the 2006 AF guidelines. So I think in 2013, you can keep that on your radar screen. Expect some new U.S.-based guidelines on AF management. Now, when you think about managing atrial fibrillation, there's three things you need to think about. Rate control, maintenance of sinus rhythm or rhythm control, and stroke prevention. And these are three legs of a stool. It's not pick one out of three or two out of three. It's three legs, and you have to think about all three in every patient with AFib. You have to think about rate control. You have to think about, are you going to try to restore sinus rhythm or not? You may choose not to, but you at least need to think about it, have the discussion with the patient, go through it in your mind. And then, of course, you need to think about stroke prevention. So let me start briefly by touching on the important issue of stroke prevention that, I know those of you that have tuned in earlier today have heard a good bit about, but I'll give you a brief, my perspective, briefly. When you think about stroke prevention in AFib, you think about risk scoring systems and what an individual AFib patient's stroke risk is. And currently, the best way to do this is the CHADS-VASc risk scoring system, which is shown here. It's congestive heart failure, hypertension, age over 75, diabetes, stroke or prior TIA, which is what the CHADS score has. But it adds in vascular disease, age over 65, 65 to 74, and female gender. And down on the bottom of this slide, you can see the relationship between the CHADS-VASc score and stroke risk. And you can appreciate if someone's CHADS-VASc score is 0, their risk of stroke is extraordinarily low, lower than the risk of a bleed on an anticoagulant. And then it goes up in a very linear fashion. So the higher the CHADS-VASc risk score, the higher the risk, the more anticoagulation is important. And I think it's important to realize this is serious stuff. Strokes in patients with AFib can cause you to either die or become paralyzed or aphasic or whatever. They're life-altering or life-ending. And when we look at all the new quality measures, pay for performance, value-based purchasing, this is one of the things that matters, is do you appropriately anticoagulate the patients in your practice? It should be. Or have you had the discussion and have you documented that the patient, you recommended they would go on systemic anticoagulation, they refused, have you documented that? I think that is going to become increasingly important in terms of a quality measure. Now, when you look at the indications for anticoagulation in the recent 2012 ESC guidelines, they've taken a new tact. They said, look, don't worry about the CHADS-VASc risk score so much. Let's just identify those patients that are at such low risk of stroke that we don't have to anticoagulate them, and everyone else should be anticoagulated. So if you look at this figure, they basically say, when you think about a patient with AFib, you ask, do they have valvular disease? If they do, they should get anticoagulated with Coumadin and warfarin with one of the old anticoagulant agents because the new ones are not approved for that. You then ask, does the patient have lone AFib totally young and healthy, no other risk factors. If they do, then no anticoagulation is needed. For everyone else, you can define their CHA2DS2-VASc risk score. If it's 0, no anticoagulation is needed. If it's 1 or 2, then anticoagulation is indicated, and there's a preference to the new anticoagulant agents because they really are more effective or as effective. They have a much better compliance with these drugs, and that's why those have solid arrows versus the dotted arrows going to the older Coumadin-based anticoagulant agents. Now, for those of you that remember the coagulation cascade from medical school, here it is. And I think we all know that dabigatran, a factor 2A direct thrombin inhibitor, was approved a couple of years ago. And then more recently, rivaroxaban, a factor 10A inhibitor. And you can remember that because it has an XA in the name of the drug, rivaroxaban. There's two others coming, apixaban and edoxaban. And all of those have the XA, so you know that's a 10A inhibitor. So we have rivaroxaban on the market now, and apixaban and edoxaban are following and should be available in the next year or 2 or 3, something like that. Now, I think you've been through this earlier, but here's some data with Pradaxa, a large study, 18,000 patients, showing that Pradaxa at the approved dose, 150 twice a day, is more effective than warfarin. At the lower dose, we don't have in the U.S. 110 twice a day, it's equivalent. But at the 150 twice a day dosing, it's superior to warfarin. And I think this is obviously a very important finding and why this drug got approved for use in the United States. With rivaroxaban, it shows similar trends. This only met equivalence, not superiority. It was a slightly smaller study, 14,000 patients. But again, rivaroxaban is equivalent to warfarin in terms of stroke prevention. And then we have apixaban, and there's 2 studies that look at this. The Aristotle study showed superiority compared to warfarin, and the Averroes study looked at patients that didn't want to take warfarin, so it randomized patients to aspirin or apixaban. And you can see in the top part of the slide that apixaban was far superior to aspirin. And in the bottom, and what I think many people were surprised by, is the bleeding risk was the same with aspirin and apixaban, really speaking to the safety of these new drugs. Now, when you compare them in terms of their various features, the things that I just want to highlight is that bioavailability, Pradaxa, is less bioavailable, less of it's absorbed into the body, more of it's in the gut. And in terms of clearance, it's more highly renally excreted. So if you have a patient with borderline renal function, it is critical that you monitor it closely, because if the renal function declines, the level can shoot up, and that's where you can get released in an excess bleeding situation. So the question a lot of people ask me is, which agent should we recommend? So the first thing I remind everyone, physicians, to do is first raise the issue, pop the question. It's sort of like Viagra or Cialis or whatever. Unless you bring it up to your patient who's sitting there in front of you, they may not bring it up to you. They may have seen the advertisements on the TV that morning, and they may be thinking about it. But unless you say, there's some new anticoagulant agents available, let me tell you about them, many patients, in my experience, won't raise the question themselves, and I encourage you to do that with all of your patients. And then how patients decide, there's a lot of variables that seem to be in play. The first is their Coumadin experience. They've been on Coumadin for many years. They've had a very stable INR level if they have a very regular kind of a diet, and particularly if they like their anticoagulation nurse, and that's sort of the high point of their week or their month is visiting that nurse, then those patients probably will stay on Coumadin. The next variable is their approach to new drugs. Some patients say, look, I hate Coumadin, let me get off this stuff, let's get it started. And other patients will say, well, it's only been approved for a year or 2, let me wait 3 or 4 years till we have more patients on it. Now, nowadays, there's hundreds of thousands of patients have been on these drugs, so I now feel very comfortable with these drugs. So why don't, those patients that are reluctant, for sort of new things, I try to tell them, look, it may be only out for a year or 2, but it's been used in hundreds of thousands of patients. We have a lot of experience. Cost considerations used to be a big issue. Now there's coupons that limit out-of-pocket copays. History of GI symptoms. Dabigatran's more likely to cause some GI problems in about 1 in 10 patients. So if they have GI problems, I tend to avoid dabigatran. Renal function we've discussed, and compliance issues. Xarelto is a once-a-day drug. Dabigatran's twice a day. Dabigatran's, the studies show that it was superior. So again, if someone's compliant, dabigatran has that superiority. If they're less likely to be compliant, I'm still very comfortable with the Xarelto. Easier to take once a day and less GI side effects. Let me move to the next slide. So let me move now on to the next issue of rate control. So again, every patient with AFib, this is a three-legged stool, you need to think about rate control. And when you think about rate control, the real question is, how do you assess it? And the way I do is you look at their resting rate, when you see them in clinic. You generally want that to be less than about 80. And I actually prefer to put a Holter on them and show that over 24 hours their average heart rate's less than 100. In my experience, that's been really the best metric for adequate rate control. There's been some new studies that have suggested that maybe more lenient rate control is adequate. I quite frankly don't buy into that message, because those studies really had better rate control than the methods of the paper suggested. So I tend to use a 24-hour Holter monitor, average heart rate less than 100. That's what I really shoot for. So now let me move on to rhythm control, maintenance of sinus rhythm. We can start with antiarrhythmic drugs, and when we think about antiarrhythmic drugs, I think all of us have learned, above all, do no harm. Think about proarrhythmia. So this is from the AHA guidelines, and breaks patients down into different classes of patients. So if you look at the far right, if a patient has heart failure, they're at high risk for proarrhythmia. We're really only comfortable with amiodarone as an outpatient, or dofetilide if that has to be administered on an inpatient basis. And I think in general, most practitioners will go first to amiodarone. Relatively few will go to dofetilide in those patients, particularly with a severely depressed ejection fraction. Now, if someone has ischemic heart disease, you'll see what's missing are flecainide and propafenone. We know that 1C drugs don't interact well with ischemia. You're more likely to get VF if you're ischemic on these drugs, so we tend to avoid those drugs, and again, the guidelines are reflective of that. If you have hypertension, then its question is severe hypertension, wall thickness more than 1.4, where you say, wow. If someone has that degree of hypertrophy, they're really at significantly increased risk of proarrhythmia, and generally will go, with amiodarone is the only drug I'll use in that sort of patient. But for other hypertensive patients, you can pretty well use what you want, amiodarone second line. And again, for those patients without structural heart disease, you have multiple offerings: dronedarone, sotalol, propafenone, flecainide, all great first-line drugs. If those don't work, you can try another, and then you can ultimately go to catheter ablation or amiodarone. Now, if you look at the ESC guidelines that were just recently published last month or earlier this month, it's basically the same message. What's missing is dofetilide. They don't have dofetilide available in Europe, so you don't see that really in this pick list, but the rest I think is consistent with the US-based approach. Now, it's important when you think about antiarrhythmic drug therapy that you think about what your endpoint is. And you have to be realistic. The efficacy of most antiarrhythmic drugs is 30 to 50% at a year, with the exception of amiodarone that's probably 60 to 70% at a year. So it's important that you tell your patients, you let your patients know that we're going to try this drug. It may work, 30 to 50% chance. If it doesn't, we have other things to use. But the other concept is that a recurrence of AFib is different than a recurrence of VF. So if you have a patient who's in AFib 24/7, you get them cardioverted, you get them on an antiarrhythmic drug, and they're having 5 minutes of AFib each month, and they that's a very acceptable endpoint for many patients. They would say, look, you've taken me from AFib all the time feeling miserable. Now I'm having just 5 minutes a month. This is great. Thank you very much. And that's a win. That's a success. You're thinking about AFib burden. You're thinking about patient symptoms and quality of life. So again, it's important to be realistic in your goals as you set out with antiarrhythmic drug therapy. And this, again, just makes the point about that. So now let me, I don't know if you want to see if there's any questions at this point before we go on to catheter
Yes,
ablation.
why don't we pause and take some questions now about medical therapy of atrial fibrillation. Would you like to comment on whether we should be using CHADS-2 or CHADS VASc score? This is CHADS-2 has been embraced by the ACC, and CHADS VASc has been adopted by the ESC. Where do you see that going?
Oh, I think the data is becoming clearer and clearer that the CHADS VASc is really superior. If you think about CHADS, the old AHA-ACC approach, they said if you're CHADS-1, you can be on aspirin or systemic anticoagulation. But a CHADS-1 patient can vary, tremendously. You can have a CHADS-1 patient who is 74 with severe hypertension, who's a woman, who has vascular disease, lots of other minor risk factors, and that patient's annual risk of stroke is probably in the 3 to 4% range, and yet the old guidelines would be saying aspirin's just fine for that patient. Now CHADS VASc forces you to say, well, that patient's really quite different than the patient who's 66, otherwise totally healthy, no other risk factors, and their risk score is quite different. So I think the world and the U.S. will go towards the CHADS VASc system. And I like the new ESC approach of saying we don't have to get into all the semantics of adding all these points together, whatever. Just identify the low-risk patients. They don't need to be anticoagulated, but everyone else with these new good drugs we have available, err on the side of anticoagulating everyone else. And I think that's the safest way to practice.
Mm-hmm. I think a related question in a patient who is very elderly, higher than 85 years old, with Alzheimer's and AFib, should we use aspirin or anticoagulation therapy?
Well, again, age is the most powerful risk factor for stroke. So that patient is at very high risk of stroke. And the older you get, the higher the risk. So the question I would ask you is that patient falling or at high risk for falling or something like that? If they were, then I would not go with the systemic anticoagulant. But if they're pleasantly demented but they're in bed or they aren't at risk of falling, I would use a systemic anticoagulant agent, most likely one of the new agents in that patient, assuming their renal function's good.
Mm-hmm. There's a question about rate control versus rhythm control. Which should be preferred? Which is better?
Well, I mean, I think a lot of physicians remember the AFFIRM study, a very important study that looked at rate control versus rhythm control. And you'll recall that the results showed it was a tie, it was a draw. The body count was the same. If anything, there was a little more strokes in the rhythm control arm than the rate control arm. But what I think physicians don't remember is who was put in that study. The patients put in that study had to be candidates for either rate control or rhythm control, meaning they had to be minimally symptomatic or asymptomatic with as they entered the study. So the patients that I'm seeing that are symptomatic, despite having their rate adequately controlled, those weren't in the AFFIRM study. I also think that fundamentally, I think sinus rhythm's better, and I have a strong bias in that direction. So if I, not uncommonly, a 55-year-old man will go in for a checkup with his physician, telling the doctor I'm feeling so great and be found to be an AFib. And the question is, what do? Do you say, well, the guy told me he was feeling fine, he must be asymptomatic, I'm just going to give him aspirin and send him on his way, or figure out his risk score for stroke? The way I look at it is, I'll say, look, this is a young guy. If we don't do something now, he's going to spend the rest of his life in AFib. So I'm going to take I'm going to discuss this with him, but the concept of going ahead, getting him on an anticoagulant, getting him a cardioverter, getting him back to sinus rhythm, see him a month later in follow-up, and see how he feels then. Because in my experience, a lot of these patients think they're just getting a little bit older. That's why they're a little more short of breath, a little less exercise tolerance, and in fact, it's the AFib with these more subtle symptoms. I think it's also important to remember that the most common symptom of AFib is fatigue. So oftentimes you'll have a patient there and their wife there, and the wife will say, well, dear, you really are doing less, and we're no longer doing this, and you just sit around watching, you tell me you're tired all the time. So again, I think a lot of patients with AFib are symptomatic, and I always will err on the side of getting it back to sinus rhythm. Some of the new data about dementia and so forth obviously impacts my efforts to sort of restore sinus rhythm in many of those patients.
There's some questions about antiarrhythmic drugs. In regards to amiodarone, we know that there are potentially serious side effects with amiodarone. When do you consider using it, and why do the guidelines suggest it?
Well, amiodarone, as we mentioned earlier, is the most effective antiarrhythmic drug, about 60–70% efficacy. And it is true that there's a lot of potential side effects. And the number I like to think about is that, at 5 years out, about 40% of patients have to stop it because of some side effect. Now, most side effects are reversible. They get a thyroid problem, you stop the amiodarone, they get better. They get, a pulmonary problem, they get better. So very few result in permanent injury or permanent harm. And it's uniquely effective, very effective. And if you really use it in a low dose, many patients have absolutely no side effects at all. So again, it shouldn't be used first line except for patients with heart failure or severe LVH. But as a second line drug in patients that really don't want to catheter ablation and they're highly symptomatic, I think it's a very good drug. And maybe it will control their AFib for 3, 4, 5 years. Maybe they'll have 3, 4, 5 years before they have no side effects. By the time they get side effects, catheter ablation may be up to 95% effective, and then we can move on and do that procedure and then there. So I have a lot of AFib patients on amiodarone.
How about dronedarone? Where do you see using that agent, and has the results of the PALACE trial affected our thinking about using this drug for rhythm control?
Yeah. So, dronedarone is like amiodarone without the iodine moiety. It has a shorter half-life, doesn't affect the liver, the lungs, the thyroid, and so forth. Doesn't have the organ toxicity of amiodarone. It also is not as effective as amiodarone. Its efficacy is really more like flecainide or propafenone or sotalol or dofetilide. So it's not as effective as amiodarone. I think it's a very good drug. I think it's well tolerated. All the studies have been done initiating it as an outpatient, so we feel very comfortable using it as an outpatient basis. It's fairly good with rate control. Now, the PALACE study is an important study that I think impacts how we use this drug, because the PALACE study looked at patients in permanent AFib all the time. And the goal was not to get these patients back to sinus rhythm. It was just to put them on dronedarone with the hopes that being on dronedarone somehow would confer additional benefits. And the study showed, in fact, the mortality increased. Many of these patients had heart failure, reduced ejection fractions. So we've learned we don't want to, if someone ends up in continuous AFib, you don't want to just leave them on dronedarone as a rate control agent. You want to get them off of it. That's really what I took home from the PALACE study. So I continue to use it. I find it's a very useful drug. I can use it safely as an outpatient, but certainly it's not as effective as amiodarone.
We'll take one more question that leads into your next topic of discussion. How does one choose between amiodarone and ablation to treat persistent AFib given minimal symptoms and little physical heart disease?
Well, the question of, for a lot of patients, you try one antiarrhythmic drug, it doesn't work, and then the question is, what do you do? Do you give up? Do you go with amiodarone, or do you go with catheter ablation? And again, patients have very different feelings. Some patients, the idea of catheter ablation, they find very, very attractive. They say, let's get it done, let's go for it, I want to get off these drugs, particularly I don't want to go on amiodarone. And other patients are very reluctant to have a significant, serious procedure. And they'd say, look, I'd much rather try amiodarone, let's have that. But again, it comes down to a big discussion with the patient about quality of life, about their symptoms, about the risks and benefits of amiodarone. Again, I'll usually err on the side of getting them back to sinus rhythm, controlling their AFib, and seeing how they do. Because once you give up and the atrium starts remodeling, it's harder and harder to get them back to sinus rhythm. Okay, well, let's move on and talk briefly about catheter ablation in our last few minutes. So catheter ablation has really changed dramatically since 1998 when the group in Bordeaux discovered that the pulmonary veins triggered AFib. This is a figure from their classic paper, again, published in 1998. So now, wherever you go in the world, if you get an AFib ablation, it will be something like this. This is one of our patients. We do circumferential isolation of the pulmonary veins, which again is where the triggers for AFib are. If the anatomy permits, we'll also go between the pulmonary veins, as shown in this figure. And we know a lot about it. We know how to perform it. We're pretty good. We know how to avoid pulmonary vein stenosis and phrenic nerve injury. We know how to avoid esophageal injury. It eliminates symptomatic AFib in most patients, improves quality of life. It's more effective than drug therapy and does have a moderate risk of complications. So this is a meta-analysis that I put together a number of years ago showing a single procedure success of about 57%, multiple procedure success with or without drugs 77%. So again, this is not WPW ablation, but again, it's pretty respectable results. Here's data from the Thermocool trial, which was a prospective randomized trials in paroxysmal AFib patients of the RF ablation technique. And again, catheter ablation was far more effective than drug therapy. But again, the efficacy you can see there, these are all world-class centers, was 64%. This is not a 95% kind of efficacy procedure. You can also use the cryo balloon. You can use a freezing technique to isolate the pulmonary veins. And the clinical trial with a cryo balloon showed quite similar results to the RF approach. Now, the risks of AF ablation have improved dramatically. This is some data from our center showing that 10 years ago, our complication rate was in the 11% range, and now it's less than 2%, with no deaths, no atrial esophageal fistulas, and no strokes in the past 5 years. The technique is really getting better. The experience really does count, and I think this kind of trend is being seen at many busy centers around the world. Now, we don't know everything. We don't know that much about long-term efficacy. What about patients who weren't in these clinical trials that got these catheters approved, those that are elderly, heart failure, long-standing persistent AFib, or upstream therapy? What's the impact of AF ablation on stroke risk, on survival? And then there's questions about, in different types of AFib, what's the best lesion set to perform? Now, we're getting answers to these questions. This is data on long-term efficacy that John Steinberg published. And if you look at that top figure, you can see that this, again, is not WPW ablation where there's no late recurrence. With AF ablation, about 1 in 4 patients by 5 years out will have a recurrence. Now, it may just be an isolated recurrence. It may be far better than it was prior to ablation, but this is not you're AFib-free for the rest of your life. You're cured, if you will. Now, he looked at risk factors for recurrence, and if you had hypertension or hyperlipidemia, you're more likely to have a recurrence. Again, the sicker you are, the more likely it is that the AFib would come back over time. Again, you still may be improved, but it may show up again. Now, there's some data, again, coming out of the Utah group, sort of very, I think, interesting data suggesting that this is sort of 3 groups of patients. Those on the right are patients that had AF that got an ablation. Those in the middle are patients with AFib with no ablation. Those on the left are patients with no AFib. And the dark bars are 1-year outcomes. And it makes the point that the patients that have AFib that get ablated, have the same kind of mortality and stroke risk and so forth and dementia risk as those with no AFib at all. And the patients with AFib, the risks are higher. Again, this isn't a definitive study, but it's sort of tantalizing and shows some of the potential benefits of AF ablation. Similarly, there's some data recently from Japan showing improved renal function after AF ablation. If you get a patient back to sinus rhythm, renal function improves. Again, sort of an intriguing, important, I think, concept. So current estimates of efficacy, optimal patient for catheter ablation, 60 to 80%, less optimal patient, 50 to 70%, poor candidate, less than 40%. Again, this is single procedure outcomes at a year. Indications, if you look at the new HRS 2012 guidelines, if you have symptomatic AFib and you failed a drug and you have paroxysmal AFib, then it's a class 1 level of evidence A indication. Persistent, class 2A, long-standing persistent, class 2B. And again, if you look at first-line therapy, you have symptomatic AFib, but you haven't failed the drug. You have paroxysmal AFib, it's a 2A. It's reasonable. You need to have a careful discussion with the patient. Persistent or long-standing persistent 2B. So let me just close by saying that the treatment of AFib is a 3-legged stool. You got to think about rate control. You got to think about maintenance of sinus rhythm. But most importantly, you have to think about stroke prevention, stroke risk, determine a patient's stroke risk, and if they are at increased risk, get them on one of the anticoagulant agents, which is one of the quality measures and most important mistake not to make. So thanks so much, and I'll stop here.
Terrific. Well, thanks. We have a few more questions. Why don't we take a question on discussion of the what is an optimal patient for ablation therapy, who is less optimal, what are the kind of factors that go into the decision making?
Well, I mean, the optimal patient is a young, healthy patient with paroxysmal AFib, so a 52-year-old man with paroxysmal AFib, otherwise totally healthy, who's failed one or more antiarrhythmic drugs and is highly symptomatic. That's the perfect patient. So in that patient, single procedure success at a year, 60 to 80%. I think the younger they are, the higher the success rate, and so forth. If you take the other extreme, you take a patient who's 87, 350 pounds, been in AFib for 5 years, lots of other comorbidities, prior stroke, and with minimal symptoms who hasn't been on a drug, that patient would be an awful candidate for AF ablation, and then it basically ranges from there. I think the point is that the more the patient's symptomatic and the more the patient has failed other attempts at therapy, the more justified you are to do an AFib ablation. So even if a patient's 87, if they're highly symptomatic, they failed other drugs, maybe they failed amiodarone, I wouldn't turn them away for AF ablation. I think pretty much everyone is a candidate, but you need to have a careful discussion about risks and benefits and expected outcomes in those patients.
There's a question about how many ablation procedures one can have. If someone's had 3 ablations, would you offer a 4th?
Yes, there's really no limit. There's actually lots of patients that have had 1, 2, 3, 4, even 5 procedures. And if you think about it, this field has evolved. So someone who had an initial ablation 10 years ago may have gotten 1, 2, 3, 4 years of benefit. AFib came back. Well, it certainly makes sense to do another procedure. Techniques are better. Usually when you go back in, you find the pulmonary veins have recovered their gaps. You can fill those gaps, and there's a very significant benefit of doing that second procedure. Same with the third procedure. There's some data that Karl-Heinz Cook from Hamburg, Germany has put together showing that until he gets to a 4th procedure, when he goes in, he always finds the gaps in the pulmonary veins, which means you always have more to do. Now, we aren't proud of that. We're trying to work on better technology to make sure we get permanent pulmonary vein isolation with the first procedure. But again, so repeat procedures, unfortunately, are something that we're faced with, but certainly it's a reasonable thing to do. Yes, patients get a little incremental radiation exposure, but in my experience, the redo procedures are easier because much of the work's already done because there's only usually small gaps to reablate.
And we'll take one more question. For patients in AF chronically anticoagulated with documented therapeutic INR, do you still need a TEE prior to ablation, considering the amount of ablating that you will do during the procedure?
Yeah.
So how do you handle that issue?
Well, this is sort of one of the new trends, as you know, Joe, is to perform these procedures. If someone's on warfarin, we continue warfarin during and after the procedure. We don't stop it, and that seems to lower stroke risk. Now, in the patient you describe who's on warfarin, but they've been in AFib, we'll say for 3 weeks or 3 months or whatever, there's a difference of opinion in the country about what to do. I will always err on the side of doing a TE in that patient, looking for a clot, because we've seen it can happen, and so that's my approach. If they're in AFib, particularly if they're high risk, they've had a prior stroke, their left atrium's big, maybe you see whatever, I'll get a TE in addition to having them on Coumadin. I know there's some very experienced electrophysiologists in the country that say, look, they just follow the cardioversion rules, and in that patient, they don't bother getting in the TE, and they've gotten away with it. I think if it was me getting the procedure, I'd want to have the security to know that there's no clot there. Now, that's different than the patient who presents in sinus rhythm, where I'm very comfortable not doing the TE in those patients, particularly if they're systemically anticoagulated.
Well, thank you very much for your time and that great presentation. I would like to thank BI for their support of this important educational series. Please remember to complete the quiz at the end of the session to secure your CME credits. My name is Dr. Joseph Marine. Thank you for joining us.